It's Friday, the 17th of January 2025, and this is the Hot Topics podcast. Happy New Year, everyone. It seems pretty ridiculous saying that on the 17th of January. You've had more than 2 weeks for the festive spirit to die at the altar of general practice. But this is the first podcast that we've done since the new year, so I still think it's legitimate. So welcome to the Hot Topics podcast from NB Medical. As usual, Neal Tucker here. And as usual, we've got 3 papers to look at from the recent journals. But let's kick off with the news first. So what's new in the news? Everyone has flu. It's that time of year. That's it. I'm not going to do any more news today. Bit of NB news perhaps. So in NB news, we've got lots of live webinars coming up next weekend on the 25th. We've got our Hot Topics course. Weekend after that, we've got our Women's Health course, Pediatrics and Child Health, Mental Health for Primary Care, Abnormal Bloods results. They're all coming up over the next week and loads more besides. We're just putting the finishing touches to our new advanced clinical practice course. So this is aimed at advanced nurse, paramedic, pharmacist, physiotherapist, physician associates working in primary and urgent care. It's going to be a whole 1-day course covering the 4 pillars of advanced practice, lots and lots of clinical updates in that, including lots of stuff on ECG and blood test interpretation. So if that's you and you're looking for a bit of an update, then do check that out. That's coming out in the middle of March. And we're just putting the finishing touches to our main Hot Topics course as well. So that'll be out in a month too. As usual, check out NB Plus, our subscription service for just over £300 a year, and you can come on all of our courses, all of our live webinars, and much more besides. Now, on to the papers. So we've got 3 papers today. Firstly, we're going to have a look at the latest edition of the BJGP and a fantastic paper on the challenges to quality in contemporary hybrid general practice. I know that doesn't sound sexy, but it's a really great paper, and I'm sure it will resonate with lots of you working in practice at the moment. Second, we're going to have a look at a BMJ paper on the use of patient decision aids to help conversations around anticoagulation in management of AF. How good are those? And then finally, we're going to have a look at a Lancet paper weighing in on this debate around whether you can treat appendicitis with antibiotics. So I really loved this month's BJGP. It's all about quality care, which is something that should be central in our minds when we're practicing and trying to help our patients. And there's a great editorial from the lead editor, Ewan Lawson, who, incidentally, we recently interviewed and will be the next in our series of special podcasts where we interview influential and interesting people from the sphere of general practice. And he's a guy who doesn't mince his words. And quick, put your hands over your kids' ears if you're listening to this. I was going to say in the car, don't do that if in your car, hold the steering wheel. But if you're somewhere else, like you're listening to this in the kitchen and you've got kids around. So he's got a great title for his editor's briefing on this month's BJGP, which is entitled The Enshittification of General Practice. Yes, that does have 3 T's in it, and is a phrase which I think possibly may have inspired this piece of research. Just this week, the news has told us that we've had the busiest winter yet for A&Es and hospitals in England. I'm sure that's reflected in other parts of the UK as well. And the same seems to be true in general practice, that we're doing more activity than we've ever done. And you've got all these statistics being thrown around. But the big question is it actually useful work? So in a few practices I've been in recently, it feels as if there's maybe a lot of duplication. So, for example, people might now access the practice by sending in an online consultation form that gets triaged into a clinician slot. So that's already 2 slots that's been taken up for one piece of activity. Or it might go to, let's say, maybe a nurse or a pharmacist, but it turns out that they're not the right person to see this problem, or it's more complex, or it's something completely different than people have written on the form. That happens not infrequently as well. And so then that needs to be put into a different clinician slot. Now we've had 3 markers of activity, but actually only one of them's really achieved anything at all. So the idea behind this paper is that since the pandemic, practices have adopted hybrid working. You're probably doing this in your practice right now, so a mixture of in-person, remote and digital contact with patients. And the authors were looking at the impact of this on quality of care. What does quality mean? Well, it can mean lots of things, but perhaps it can be measured through effectiveness, efficiency, safety, patient-centeredness, equity, continuity, accessibility, and I'm sure there's lots more ways that you could look at it as well. The study was conducted across 28 months, 12 different practices in England, Scotland and Wales with different levels of digital evolution, and the researchers often embedded themselves within the practice and then collected data on how the practices were doing, how they were changing over time, and also conducted interviews with staff and patients as well. They found a number of themes emerging, so increasing complexity, not just clinically, although there were more complex patterns of illness, so older populations, greater levels of sickness, social isolation, greater levels of consulting, but also increasing complexity in the technology that we use. We're trying to get our heads around these plethora of tools that are constantly being thrown at us and trying to get your head around the latest one. And also complexity operationally. We've now got lots of different members of staff, and that can make things more difficult to navigate as well. Another theme was financial austerity. So that's putting pressure across all aspects of the NHS, of course, and unsurprisingly, all of us are trying to shift the pressure away from ourselves onto another. And of course, it just goes around in circles in some kind of zero-sum game. But those financial pressures are obviously having an impact. Then we've got the changing workforce. And obviously, there's nationally a lot of political discussion going on around the changing workforces in general practice at the moment. But there was a really interesting comment from an interview with a senior receptionist that they put in the paper. So they said senior receptionists confided that newly recruited support staff in particular sometimes became disillusioned and left quickly as the full demands of the role became apparent. I wonder if this might be the case for clinicians as well, clinicians of all types. Thrust into general practice, hoping for a better life and then realising that it's absolute mayhem. Another theme is novel technologies being adopted or sometimes maybe imposed upon practices, but being let down by the poor digital infrastructure. Speed, capacity, functionality. We've all had problems with these on a day-to-day basis. And also the purchasing decisions about those technologies are often outside of practice control, adding to further frustration. And there's lots more, but for me, one of the other standout ones was loss of in-person interactions between staff. As we all get busier and busier, it's difficult to actually see your colleagues. And this has lots of important consequences. It's so valuable just for our souls to be able to have a little bit of downtime for ourselves and with our colleagues, with other people. And also this huge value in being able to discuss cases as well, share knowledge and share ideas. But that's being lost if we can't meet up. There were positives about the hybrid system, so convenience, flexibility, improved data capture were cited as benefits. But the authors highlighted there were often trade-offs here. So whilst you may make improvements in one quality domain, that often led to compromise with another. For example, care and compassion may be traded off for efficient transactions, choosing to send that text rather than calling a patient because you know, at least in that moment, it's going to be quicker. Access and triage let people send in online consultations, but running up against a mismatch with capacity. The authors noted a number of unintended consequences of hybrid working. loss of organizational efficiency. So more of us are needed to do more triaging. We're not then seeing patients. Some of those online consultation triage forms just give too much information. We're spending lots of time trying to filter through that. What about the time wasted calling patients back when they don't pick up? Many minutes of your day. Then, of course, you probably leave a message. The patient then phones back. They talk to a receptionist. Now we've used yours, the patient's, and the receptionist's time, and still we've got nowhere. It's a system that can demonstrate they're doing more activity than ever, but being remarkably less efficient. Loss of patient-centeredness, threats to safety, loss of continuity, the list goes on. Issues around equity are really important. So part of that is accessibility, how you help patients who are less digitally enabled. So vulnerable groups, the older, the sicker, those with more complex needs, those from deprived backgrounds, patients where English is not their first language. These are all barriers to people using digital technologies and creates further health inequalities. In one section, they talk about personalized versus protocolized care, and they suggest that perhaps we're turning into data processors, a truly depressing vision. I briefly thought that maybe you could argue that all of clinical working is data processing. We take symptoms and signs, investigations, family history, social situations, and we process this and form a working theory. We've always been extremely smart, complex data processors. But when you get a pro forma that's coming on an e-consult with 100 different questions that's been asked and you're filtering through these, what that really represents is the loss of the personal. It's transactional, sterile. Are we simply to be a logic gate? If X occurs, do Y? For me, that's the death of general practice. And while it feels like I've gone down a bit of a dark hole right now, the authors conclude that the picture is not universally bleak. There is evidence of systematic erosion of the less measurable and the more humanistic elements of quality general practice. But having recognized this, it's an opportunity to flip this back on policymakers and ask what can be done to retain and strengthen those core elements of primary care. And if you agree with the findings of this paper, as usual, the link is in the podcast description. It's really worth taking a look. Then this data could be used as a springboard towards better practice. Let's take a look at our second paper now. And this was published in the BMJ this week. The title is Effectiveness of Shared Decision-Making Strategies for Stroke Prevention Amongst Patients with Atrial Fibrillation. And I feel like this is kind of connected to the previous paper because perhaps there's a discussion around protocol versus personalization here. This was a randomized controlled trial performed in the US, 1,100 adult patients with non-valvular AF and a CHADS-VAS score that really suggested they should have some anticoagulation. The patients were then randomized to either have a patient decision aid before the consultation or usual care, and the clinicians were randomized to use a encounter decision aid, so a decision aid that you use with the patient in the consultation, or to usual care as well. And then the information that was given in these decision aids, so they were interactive online tools informing patients about their risk of stroke, risk of bleeding, what the benefits versus the risk would be of any individual treatment and the different treatment options. There were 3 primary outcomes that they were examining, so quality of decision-making, patient knowledge, and patient decision-making. So although this is a quantitative piece of work, it feels a little bit like a qualitative piece of research. The results showed then that compared with usual care, use of either or both decision aids improved the quality of shared decision-making, improved patient knowledge, and reduced decisional conflict. Now, that's a phrase, if I'm honest, I don't fully understand what it means. Is it my confused and flustered id, or is it like some kind of versus battle you have with the doctor during the consultation? I don't really know. But the authors concluded that all of this meant that the patient decision aids are great. Score 1 for patient decision aids. Presumably good news. I've just been writing up the menopause section for the new Hot Topics course. The updated NICE guidelines have a new, fancy, quite long patient decision aid. They've done this with many things as well, included things like lipid modification. Patient decision aids, they are all the rage, and they seem intrinsically like a really good idea. The paper also reports on a few secondary outcomes. So one of them was looking at treatment choices for stroke prevention, and compared with usual care, use of a patient decision aid did not change the treatment choice for stroke prevention. They also looked at patient satisfaction. It turns out patients were no more or less satisfied using a patient decision aid than if they didn't. Lastly, they looked at consultation times, and they found that using a patient decision aid added about 1 minute onto a consultation, which they considered to be a negligible difference. I wonder if you would consider an extra minute in your consultations to be a negligible difference. So the authors didn't really focus on any of this, but it seems to me that here we've got data showing that the outcome for choice of anticoagulation is unchanged. Patient satisfaction is unchanged, and the consultations are a bit longer. And the only thing that's really changed is that patients are a bit more knowledgeable about their treatments. Now, I'm all for knowledge. I spend a lot of time talking and educating patients during my consultation. And what I've come to realize is that some people really like this, whereas others just want me to shut up, get on with it, and tell them what to do. Just the facts, ma'am. I don't know where that came from. Well, I do know the source. Just the facts, ma'am. That's a phrase from the film Dragnet, 1987, Dan Aykroyd and Tom Hanks. A film of my youth. No idea if that stood up to the test of time, but it's not a reference to me cross-dressing when consulting in the practice on a Tuesday. Anyway, I digress. If only I could work out who wanted to be educated and who didn't want to be educated before I started that process. That would be a wonderful thing for all of us. Anyway, in conclusion, in clinics in America, using a patient decision aid to help with discussion around anticoagulation for stroke makes people more knowledgeable about their treatments, which is probably a good thing. It reduces decisional conflict, which no one knows what that actually means, but doesn't alter treatment decisions and doesn't improve patient satisfaction. And I'm going to let you all discuss amongst yourselves, therefore, whether you think that it's worth it or not. Now, onto our final paper in The Lancet, and this is titled, rather sportingly, Appendicectomy versus Antibiotics for Acute Uncomplicated Appendicitis in Children. I feel like we must have had some data on this in the podcast before, but I haven't got the time to go back and actually look. Regardless, this new research definitely adds to the discussion. So, common problem. The authors report the lifetime risk of appendicitis is 6 to 7%. Gold standard is obviously chop it out. And despite modern imaging, apparently 5% of kids with suspected appendicitis don't actually have it, which of course would mean then doing an operation on those is not a good thing. Anyway, it all seems like rather a lot of effort compared with just giving them a packet of antibiotics. But of course, does it work? Well, the data so far is quite positive about this concept. In fact, there was a National Institute for Health and Care research alert in 2019 highlighting a randomized controlled trial in Finland of 530 adults with uncomplicated appendicitis confirmed with CT scan and then given antibiotics, so levofloxacin plus metformin, or surgery, and they found that in around 60% the appendicitis settled and did not come back over the next 5 years of follow-up. The NIHR seemed to think that this was a really good thing. To me it sounds kind of okay, not that great, but the flip side was that 24% of those having surgery had some kind of complication versus 6.5% on antibiotics. So I guess perhaps everything kind of evens itself out in the end. An existing study into children that they report in the paper, albeit a non-randomized study, found that 2/3 avoided surgery at 1 year with fewer disability days. So that does sound promising, but what this new study represents is the first large randomized controlled trial in children. They recruited 5 to 16-year-olds with simple appendicitis. And what was really nice about this study was that they were trying to make it very pragmatic. So rather than that Finnish study where they'd had to have the appendicitis confirmed by CT, in this multi-centre, multinational trial, you actually didn't need to have radiological confirmation. It wasn't a prerequisite, raising the possibility that this could actually be applied in a primary care setting. So 936 patients, roughly spread 1-to-1 between antibiotics and surgery. If they were given antibiotics, they received coamoxiclav or cyprometronidazole if they were penicillin allergic. For surgery, they would almost exclusively have laparoscopic appendicectomy, and then they followed those children up over 12 months. Treatment failure occurred in 34% on antibiotics and 7% in the surgery group. And of those treatment failures in the surgery group, it turns out that all but one of them were because they actually didn't have appendicitis in the first place. Surprisingly, kids who had surgery actually stayed in hospital for a shorter duration than those who had antibiotics, with the paper suggesting that kids could go home straight away after their operation. Classic surgeon. But they also reported that there were no deaths or serious adverse events in either group. Based on the findings, the authors concluded that antibiotics were inferior to surgery, and despite actually having quite a generous permitted 20% non-inferiority margin, antibiotics still failed to meet that threshold. What can we learn from this? We're still going to need to make that uncomfortable call through to the surgical team at the local hospital if you've got a kid that you think has appendicitis. No, I haven't done a PR because they're a kid. No, I haven't got a urine because they're grossly dehydrated. Yes, I think they should come to you, not the medics, because it's an appendicitis. Listen, Sonny Jim, I was doing your job 20 years ago. Be firm, people. That's it for the research. Thanks for listening to the podcast as ever. We'll be back in 2 weeks with our special interview with the BJGP editor, Ewan Lawson. We'll be back in 4 weeks with the next regular Hot Topics podcast. In the meantime, don't forget to check out nbmedical.com. Have a look at those courses that are coming up and all the other great stuff on the website. You can always get in touch by emailing on hottopics@nbmedical.com. or find us on social media platforms. Cards on the table. You probably won't find me on X anytime soon, given the fact that Elon Musk has gone off the deep end for me, and I always found Twitter a pit of misery. Anyway, each to their own. In the meantime, have a great weekend. Look after yourselves. We'll see you next time. Bye-bye.